Hey everybody, Dr. Becker. We're going to jump into chapter 51, birth control. So essentially, birth control is part of women's health, and essentially what that is we're going to be interfering with the reproductive process. Uh, Technically, birth control was made to prevent birth, right? But it's also used for treatment of acne, treatment of dysmenorrhea, and a couple other things that people can be on birth control for, even if they're not sexually active. I'm going to show this slide here again in case it's been time between chapter 50 and 51 for a quick review to have for your notes of the menstrual cycle, because essentially what we have to talk about now is how do we interrupt this cycle to prevent pregnancy. So birth control can be accomplished any time in this process, from interfering with gametogenesis to nidation, which is the implantation of a fertilized ovum. The methods of birth control include oral contraceptives, implants, intrauterine devices, vaginal rings, transdermal. We have a whole lot of varieties. Most of them are considered reversible forms of contraception. Sterilization is used often, but it's not reversible. Let's jump into effectiveness of birth control. The effectiveness of a birth control method can be expressed as the percentage of unplanned pregnancies that occur while the method is being used. So your table 51.1 breaks this down for us nicely. Okay, so birth control, under that first one it says no method. Okay, the actual use is 85%, theoretical rate is 85%. So 85% of people that are not on birth control are likely to conceive. Okay, then we have what they consider to be extremely effective versions of birth control because the actual failure rate is 0.05%. Okay, the difference between the actual use and the theoretical use is funny to me, but that's not funny, but it's kind of funny because what they're saying is actual use is what we see in observed practice. Theoretical use is if people would actually use the birth control the correct way. So the biggest problem with birth control is people don't do it right. You forget a pill, you don't whatever, they don't take it at the same time of day, whatever. So failure to use it correctly is the actual use, and then theoretical use if they were absolutely perfect human beings that never took the drug wrong situation. So extremely effective would be like the subdermal implant, the Nexplanon. Only 0.05% of the people using it correctly or using it in practice are going to have a conception to pregnancy. So surgical sterilization is not 100%, right? We know that male vasectomy and female tubal ligation, people can still have pregnancy after. And then the intrauterine devices work very well. Copper T, Paragard, or the levonorgestrel, which is the Mirena, have less than 1% unintended pregnancy with both actual use and theoretical use. Then we have very effective, effective, and least effective. So like least effective is like spermicide alone. 29% of people in theory could still get pregnant. Periodic abstinence and withdrawal, all of these things are not very effective. Condoms, for the male condom, still has a 15% theoretical, 15% actual use. So 15% of people using a condom could get pregnant, and if they did it the right way, appropriately, whatever, it's still 2%. So that's not without the possibility of unintended pregnancy. So that's what that section in your book is talking about. All right, so selecting a method of a birth control. Kind of where do we go from here, and how do you pick what people want to be on and all of those things. So there's a couple things you have to think about. One is effectiveness, obviously, safety, and then personal preference and what is the safest for the patient. The remaining methods, like we talked about, condoms, the sponge, diaphragm, spermicides, must be used in a near perfect fashion to afford any reasonable level of protection. And that is something that I would use like that lingo to talk about when you're counseling men and women, okay? Like they're sold. Could they be? They have, I mean, you cannot mess up with these, or you're likely to have an unintended pregnancy. When safety is a factor into the equation, there's a lot of things that come into play. Whether or not their age, their cardiovascular risk, or whether or not they're smokers, for example. Some would be safer than the others. So how safe is it? How effective is it? And then their personal preference all go into what decision is made. The other reason that personal preference is such a big deal is because if you could do what they prefer, they're going to adhere to it better. So if you talk somebody into, they're like, I really don't want to use a transdermal, and you talk them into it and they forget to go back and get it, you haven't done them any good. The other thing that goes into these decisions are also family planning. Do they want to have children? But later, have they already had the children that they want? Would they consider sterilization? There's a whole bunch of context that can go into it. Okay, but let's talk about oral contraceptives, which are abbreviated as OC. There's two main types, right? So we have estrogen plus a progesterone, which is a combination OC. Then we have some that just contain progesterone, which is the mini pill. Okay, by far and away, combination OCs are the most used. The prototype for the combination OC is the ethinyl estradiol / norethindrone combination. Okay, so combination OCs reduce fertility primarily by inhibiting ovulation. So let's talk about that a second. The estrogen that you take in an oral contraceptive suppresses the release of the follicle-stimulating hormone from the pituitary. So you're going to prevent this maturation of the ovum to get into here to burst to be fertilized. Okay, so having the estrogen is going to suppress our pituitary from releasing the follicle-stimulating hormone. And then the progestin in combination acts in the hypothalamus and the pituitary to suppress the mid-cycle luteinizing hormone surge that even triggers ovulation in the first place. So by giving estrogen, the FSH is decreased a lot, and therefore the ovary doesn't necessarily have the signal to mature the ovum. And the progesterone then prevents this sharp decline of the LH, and so then fertilization is not likely to occur. Secondary mechanisms include thickening of the cervical mucus, right? Remember that it doesn't actually become then watery. The watery mucus is when people should be knowing that they're ovulating, and therefore that's when they have an indication to try to get pregnant. So if you thicken the cervical mucus with these drugs, it creates an actual physical barrier for the penetration of sperm. Also, because you've now manipulated this FSH and LH, you have changed the lining of the endometrium, and it doesn't rise and become this hospitable place anymore, and it makes it less hospitable for any implantation if it were to occur. So we have some components that are the estrogen only, but most of the products use ethinyl estradiol in combination. There's a newer product called Metasia, which uses the estradiol valerate, which undergoes conversion to estradiol in the body. Progestins in the combination, we have 8 different ones that can be grouped into 4 categories of the combination pills. First generation then is the ethinyl diacetate with norethindrone. This is table 51.2 in your book, and this is a really helpful one. It's mildly androgenetic and a lower risk for thrombosis. Second generations are the levonorgestrel and the norgestrel. Then third generation, fourth generation. Interesting, the fourth generation has the greater risk for thrombosis than with any other of the progesterones, but it has less androgenic effects, so it has a less of a risk for acne or hirsutism. So really what I want you to know by this is that progestins are used with different generations, or the different generations of progesterones are used with the estradiol. Other thing that's really important to know is that among women with higher weight, efficacy of oral contraceptives tends to be reduced. Possible reasons include decreased levels of their hormones or sequestration of some of the hormones in adipose tissue, and then just your altered metabolism. So the book says that even though they may be less effective, they are still more reliable than other alternatives. The initial studies that were done on oral contraceptives were done with doses that were much higher than we use now. So we'd still need a lot of newer data to really monitor and follow these more long term. Possible adverse effects. So combination oral contraceptives adverse effects are listed here. The current consensus is that if the history reveals an absolute contraindication, OC should not be prescribed. And then there's a list of relative contraindications that they should be used cautiously. The current consensus by the World Health Organization and by ACOG suggests that birth control can be safely prescribed after a thorough medical history and blood pressure is taken. You do not need a full pelvic exam to prescribe an OC. Some states in the United States actually allow the pharmacist to prescribe the contraceptive. Table 51.3 is the one I would like for you to be familiar with and what you would go to for reference and for your patients. We have absolute contraindications to birth control, and I want you guys to see what these are and know them. Okay, these are really important because, like I said, we now have over-the-counter versions of birth control that have recently come out. So these are really important to understand. There are some reasons that you absolutely should not be on an oral contraceptive. Any thromboembolic disorders, cerebrovascular disease, coronary occlusion, or a history of those, or a condition that predisposes to these disorders. Okay, so, what does that mean? That's my question to you guys. Like, what does that mean? If you had a 27-year-old morbidly obese female that had off the charts lipid panel and triglycerides through the roof, super unhealthy, and smoked, and both of her parents died at the age of 50 from heart disease and all those things, I mean, she's got conditions that predispose her to coronary artery disease for sure. Is that an absolute contraindication? So it's kind of a vague, abstract definition to me. The other thing they put in here is your abnormal liver function, known or suspected breast cancer, undiagnosed abnormal vaginal bleeding, known or suspected pregnancy, and if they're a smoker older than 35. I cannot tell you how many women I know that have been given oral contraceptives that are smokers that are older than the age of 35 and have never been told anything about it in their lives. And I can't believe it, but it happens a lot. I'm not saying that I'm against birth control. What I'm talking about, though, is that I feel like we've gotten pretty lackadaisical about using it appropriately and prescribing it appropriately. Then we get into the relative contraindications, and those are still also a little bit, diabetes, hypertension, heart disease, cholestatic jaundice of pregnancy, if they have a bad gallbladder, if they have a uterine leiomyoma, if they have a history of epilepsy or history of migraine. Thromboembolic disorders is the big one. The combination oral contraceptives have been associated with an increased risk for VTE, thromboembolism, pulmonary embolism, MI, or stroke. The relative risk for a thrombotic event is 2 to 3 times that of a risk of a non-OC user. However, this absolute risk is still what they consider to be small. So when when the health people, the people look at it, they say the risk for thrombosis with oral contraceptives is still considered lower than the risk associated with pregnancy and delivery. So that's how they kind of argue that that's a safety profile for that. The problem is that oral contraceptives promote thrombosis in part by raising the levels of the clotting factors, which is what I said before, when we know that estrogens affect both ways of bleeding and increase in clotting factors. So now if we're giving someone who has enough normal endogenous estrogen and we want to manipulate that in their cycle, that we give them excess doses of estrogen, that's where the problems come into the possibility of more problems, is what I'm trying to say. We do know that it's been safer since we've been using much lower doses of estrogen. Today's oral contraceptives contain no more than 50 micrograms of ethinyl estradiol, so that's a good thing. Major factors that would also increase your risk, though, include such things as we said, diabetes, hypertension, coronary artery disease, stroke, but also surgery. So there has been some questions and dialogue that I've seen about whether or not people should be off of their oral contraceptives for expected surgeries and some of those different things, because immobilization also is going to increase your risk for a thrombotic event. And again, it's 35-year-old or older that's a smoker that has the really higher risk for a thromboembolic event. With today's low estrogen, non-smokers may continue oral contraceptives until menopause with no greater risk for MI, but several measures can help minimize thromboembolic phenomena. The estrogen dose should not be greater than that required for contraceptive. The OCs containing drospirenone or desogestrel should generally be avoided in these older population. OC should not be prescribed for heavy smokers, women with a history of thromboembolism or risk factors, and OC should be discontinued at least 4 weeks before surgery in which postoperative thrombosis might be expected. Oral contraceptives also have a black box warning that cigarette smoking increases the risk of serious problems. Okay, the next one then too is cancer. OCs present no known risk factor for cancer, with the important exception of promoting breast cancer growth, but not causing it. The effects of oral contraceptives of cancer of the ovaries, endometrium, cervix, and breast have been studied extensively. OCs actually protect against ovarian, endometrial, and then they have no positive or negative effect on cervical cancer. Breast cancer now shows that it doesn't cause breast cancer, but if you have breast cancer and you're on OC, it's going to promote the growth of the breast cancer. Also of importance, oral contraceptives do increase the risk for some women, specifically those who have the BRCA gene mutation, because they already have such a significant risk of breast cancer. So BRCA1, but it's not the same as BRCA2. So BRCA1 women should probably not be on oral contraceptives. Hypertension. Okay. Combination oral contraceptives can cause hypertension, but the risk is much lower when we use these low dose preparations. But it can raise the blood pressure by increasing the blood levels of angiotensin and aldosterone. If high blood pressure develops and OCs are determined to be the cause, you can discontinue it, or you can continue and then give them antihypertensives. Also, abnormal uterine bleeding. Because we're altering the endometrium, we can decrease or eliminate menstrual flow, but we also can cause breakthrough bleeding and spotting, especially with the use of extended cycles like seasonique or seasonale. Spotting and bleeding can also occur with monthly cycle OCs, most often during the first 3 months when low estrogens are used. If a woman misses her period while taking monthly cycle oral contraceptive, the possibility of pregnancy should be assessed. After discontinuation, normal menstruation usually resumes, although the first period may be delayed. Women with a pre-treatment history of irregular menses should likely and will likely return to their previous pattern when you stop the OC. OCs have no therapeutic role during pregnancy and are contraindicated for use by pregnant women, so pregnancy should be ruled out before starting oral contraceptive. And if you find out you're pregnant on oral contraceptives, you should stop immediately. Combination oral contraceptives does enter the breast milk and can reduce milk production, especially in the early stages of lactation. But in contrast, progestin only have little or no effect on milk production, And so those are when the mini pill are preferred for contraception during lactation, at least early on. Later down, months down the line, when the milk supply is well established, you could potentially use the oral contraceptive. All right, then stroke in patients with migraine. When used by women who experience migraine headaches, oral contraceptives may increase the risk for thrombotic stroke. Because the risk is low, oral contraceptives are generally considered safe for women with migraine, provided they're younger than 35, they don't smoke, and they are healthy, and they're provided their headaches do not cause an aura. All right. The next adverse problem I talk about is the effects related to estrogen or progestin imbalance. So table 51.4 shows the side effects caused by an excess of or deficiency in estrogen or progesterone content of an oral contraceptive. So if you have too much excess estrogen, you can get nausea, breast tenderness, edema, bloating. If you don't have enough estrogen, you can get the breakthrough cycle bleeding. Examples, it's all listed here. So there is a fine balance of these, and if you find someone complaining of the symptoms, consider this chart, and maybe you have an excess or a deficiency in one of the hormones. The other problem too is that glucose intolerance happens with oral contraceptives. Oral contraceptives can elevate blood glucose levels. This diabetogenic effect is caused by the progestin in the OC. Glucose intolerance is most likely in patients who are already diabetic or who have had in the past gestational diabetes. The presence of diabetes, though, does not preclude someone from using it because we have drugs that can treat the blood sugars. Pre-diabetic women should be monitored for the development of hyperglycemia, and glucose intolerance may be less likely to occur with oral contraceptives that contain the desogestrel or norgestimate. So that's why these could be finely tuned to kind of the specificities of the patient. Also, I said there is some reason that there's non-contraceptive benefits of oral contraceptives, and that, remember, could be things like decreased risk of ovarian cancer, pelvic inflammatory disease, benign breast disease, iron deficiency anemia from dysfunctional uterine bleeding or dysmenorrhea, and then people go on it also for acne. Some people also can use it because women can have diminished cramps, lighter or shorter or more predictable flows associated with that. All right, drug interactions. Most of the OC drugs can have accelerated metabolism when taken with a CYP3A4 inhibitor. So there's a possibility of that. And you may have to adjust your oral contraceptive. The interesting one, though, is that oral contraceptives can decrease warfarin benefit and can decrease hypoglycemic agents. So by increasing levels of clotting, the oral contraceptives can decrease the effectiveness of warfarin. And then by increasing the levels of glucose, oral contraceptives can counteract the benefits of insulin and other hypoglycemic agents. So oftentimes you have to have adjustment of dosing if you're on oral contraceptives and warfarin or oral contraceptives and diabetes. Also, oral contraceptives can impair the metabolism of several agents, including tricyclic antidepressants, diazepam, and Librium. So you have to be prepared for dose adjustments there. The common combinations of drug options is in table 51.5. I do want to point out that you have drugs that are monophasic, biphasic, or triphasic, and then extended cycle type drugs that are listing there. Quickly before I forget, I am going to mention the drug called Yaz Plus or Bayaz, which is an estrogen and progestin, but it also contains levomethylate, which is a metabolite of folic acid. So the purpose was to reduce the risk for fetal neural tube deficits if pregnancy should occur despite contraceptive use, which I find crazy. That really tells you how mismanaged people are sometimes in the use of the contraceptives, that they actually felt it was worthy to make one that's safer to use in case you accidentally screw it up and do get pregnant. Just pointing that out. But again, talking about those dosing schedules. For most products, they assume a menstrual cycle is 28 days. Some products can extend or be continuous. For a 28-day cycle, they can be monophasic, biphasic, triphasic, or quadriphasic. So I want to talk about that a little bit. In a monophasic regimen, the daily dose of your estrogen and your progesterone remain constant throughout the cycle of use. So you have one level and it stays that way the entire time. Mono, one level, whole thing. In the other ones, the estrogen and progesterone, or both, will change as the cycle progresses. So the biphasic, triphasic, and quadriphasic schedules reflects efforts to more closely mimic our ovarian production of estrogen and progesterone, but there's really no documented and reproducible benefit over the monophasics. So when you go up to that 28-day cycle chart of 51.5 table, when you go down to like a biphasic, you have a phase 1 for 20 days is one dose, and then the next 10 days is one dose, is a different dose. So again, that's what that means, and it's not necessarily that anything is better one over the other. Most 28-day cycles per products are taken in repeating sequences where you take 21 days of an active pill, followed by 7 days when you either don't take a pill or you take the inert placebo pill, or not placebo, inert pill, or some of the contraceptives now even have 7 days of an iron-containing pill, so that during the time of the menses, the female's taking iron. The sequence is begun on either the first day of the menstrual cycle or the first Sunday after the onset of menses. So if you're starting somebody on birth control, you either say start this on the first day of your cycle, or some people really want to start on a Sunday, then you say the first Sunday after your onset of menses. So if the female begins bleeding on Wednesday, the following Sunday they would start the cycle. With the first option, protection is conferred immediately, so you don't have to have backup contraception. But if they started on a Sunday or a particular day of the week, randomly, you may have to realize that you may not have immediate protection, and so you should have an alternate form of birth control during the first 7 days. The most important thing, honestly, and it's like you hear this all the time, and I don't know that people really pay attention to it, is that you have to take your pill the same time every day. If one morning you take it in the morning, and the next one the female takes it in the evening, and the next day she takes it at lunch, that really puts them at risk for an unplanned pregnancy. If you're going to use them correctly. And that's why they actually have data that'll tell us when people screw it up, because almost everybody does, here's the risk. And one of them is taking it at the same time every day with food or something like that. Successive dosing cycles should commence every 28 days, even if you have breakthrough spotting or bleeding. Some people recommend taking the oral contraceptive combo for an extended time rather than doing the traditional day cycle where you have the 7 days of an inert pill, because you have less chances of withdrawal bleeding. You can have no period at all, and therefore you can have like no cramping and just feel better, and why do we need to have a period type of thing. Prolonged use of oral contraceptive is possible because these drugs suppress endometrial thickening, so monthly bleeding is not required to slough off hypertrophied tissue. You can use a monophasic pill that has the 7 days of inert and just skip the 7 days of the inert and pick up with the next 21 days and just continuously back to back without any inert breaks, and that's how you create a continuous schedule. What to do if doses are missed? The risk for pregnancy from missed doses increases with each successive omission. So if one or more pills, it's all in there of what you would do. and how you would restart it and all those things. The important note here is that the response to a missed dose of the Natassia is more complex than that with either combination oral contraceptive. And remember that the Natassia is the estradiol valerate and the Dienogest, which is a fourth generation progestin. Because estradiol valerate is the prodrug that undergoes rapid conversion to estradiol, and then you have the Dienogest, which is much like drospirenone. So because it's kind of different, it's all over the place, you have to be careful with the Natassia. So there would be information on the insert to tell you what to do for that. And then getting further on, the progesterone-only contraceptive was the mini pill. They do not have estrogen, right? So they do not have the effect of the thromboembolic, headache, nausea, and some of those things. However, they could be considered safer than the oral contraceptives, but the progesterone-only preparations are less effective and they are much more likely to cause irregular bleeding. And so women don't necessarily like them. And so that irregular and unpredictable bleeding is mostly why people don't successfully take those long term. It's really best and most tolerated for lactating women. The contraceptive effects of the mini pill result largely from altering the cervical secretions, because under the influence of the progesterone, the cervical glands will produce that thick, sticky mucus that is a barrier to the penetration by the sperm. Progestins also modify the endometrium, making it less favorable for implantation. So in order for these to be really effective, these definitely have to be taken the same time every day. Even 3 hours missed too late can offset its protection from pregnancy. All right, then, I don't know why the slides didn't progress on here. Let's talk about transdermal. All right, so we have some options for a transdermal contraceptive patch. The patch has the same efficacy and the same incidence of breakthrough bleeding and spotting. The principal difference between them with oral contraceptives lies in their schedule. The patch is applied just once a week. So it's much more conducive to people and can be a much better option for people. And some say that the adherence is better, but I've also run into women that just forget to change the patch. So either way, if you don't pay attention to the dosing of the contraceptive, whether it's a pill or a patch, it's going to be a problem. After the release, the hormones will penetrate the skin, enter the capillaries, and undergo distribution throughout the body. It takes about 2 days after the patch is applied to really kind of have plateau levels. For women not on a previous oral contraceptive, the patch should be applied during the first 24 hours of their menses. If you're switching a woman from an oral contraceptive, the patch should be applied on the first day of withdrawal bleeding. In clinical trials, 4% of the patches would fall off or come detached. And if the patch has been off less than 24 hours, you don't have to have backup contraceptive. But if the patch has been off for more than that, a new cycle should be started and they should use backup contraception. The adverse effects of the patch could be breast discomfort, headache, local irritation, and menstrual cramps. And it can have a higher incidence of more painful bleeding when they do have their period. There is some question as to whether or not the patch actually has a higher risk for venous thromboembolism, and the answer is maybe. All right, then there's the vaginal contraceptive ring. And that's the Nuva ring, and that's vaginal insertion is needed. That's also an estrogen-progestin combination. The adverse effects and drug warnings and all those things are the same for the oral contraceptives. They place the ring once each month, leave in place for 3 weeks, remove, and then reinsert a week later, and they should have bleeding during their ring-free week. This also can cause some local symptoms of like vaginitis, Some people don't like the way it feels. Some people feel like it interferes with their sexual intercourse. Some people feel like it causes irritation. But a lot of people can use this and not notice that it's in at all. Okay, and then we'll create a new slide for you here for the long-acting contraceptives. Okay, so the first one they talk about is the Nexplanon, which is subdermal. It delivers etonogestrel for long-term reversible contraception. It's among the most effective contraceptive available. That's where its benefit lies. It consists of a single 4-centimeter rod that contains 68 milligrams of synthetic progestin. The rod is implanted subdermally in the groove between the biceps and the triceps in your non-dominant arm. And then over time, the etonogestrel diffuses slowly and continuously, providing blood levels sufficient for contraception for 3 years, and then the rod is removed. A new rod can be implanted after 3 years. Recent studies have shown, though, that Nexplanon can continue to be effective for even up to 5 years post-insertion. That etonogestrel suppresses ovulation and thickens the cervical mucus, so it causes the endometrium to become involuted and hostile to implantation of a fertilized ovum. Has the potential for some drug interactions. In women using Nexplanon, bleeding episodes can be irregular and unpredictable. So you can have amenorrhea where they don't have a period at all. They can have infrequent bleeding, frequent bleeding, intermittent bleeding, all those things. So there's a pattern of irregular and unpredictable bleeding that can happen. That is the most common reason that people get the implant removed. The other thing is that it is safe to have during breastfeeding after 21 days postpartum. So that's another maybe added benefit for women. The next one is the Depo shot, which is the depomedroxyprogesterone acetate, DMPA. So it's given by intramuscular or sub-Q injection. It protects against pregnancy for 3 months by inhibiting the secretion of your gonadotropins. So it inhibits follicular maturation and ovulation, it thickens the cervical mucus, and it causes the thinning of the endometrium, making implantation unlikely. Most fertility will return when you stop the injections after 9 months, but sometimes you can still stop it and not be able to get pregnant for some time afterwards either. This also can cause some menstruation irregularity, but usually if you continue to take it over time, the menses cease entirely. Most women will gain a pound or 2 the first year. They may have abdominal bloating, depression, decreased libido, all those things. DMPA, the Depo shot, does possess a risk for reversible bone loss, but it doesn't outweigh the benefits of treatment, is kind of what they say. When your DMPA is discontinued, your bone mineral density returns to pre-treatment levels typically within 30 days. So, because there is some change in the bone mineral density that can decline rapidly in the first 2 years, the FDA now has a black box warning. It recommends against the Depo shot for more than 2 years. There's a lot of newer suggestions from the ACOG and other people that you don't necessarily have to limit that to 2 years. And I think we may be able to see some of that change when it comes, to fruition over the next couple years. I have not personally looked up the Depo shot in terms of recent changes since 2022, 2023, so I'm not sure because it's just not something that I see all the time. But yes, there is still a black box warning with it. And then we have intrauterine devices, and these have grown wildly in popularity because they're, number one, they're very reliable, and number two, they're very easy. For women, they're considered that you can put them in and forget about them. They don't require remembering when to take a pill or put on a patch or put in a ring. They get put in and they're left there. Historically, way back in the day, there was some increased risk of pelvic inflammatory disease related to IUDs, but that was in the formulation of the IED, and now they're very safe to use. Gonorrhea and chlamydia infections are associated with the risk of pelvic inflammatory disease, so you should have screening done for that prior to insertion. The risk for PID is highest during the first 20 days, and then it drops off rapidly after that. IUDs, though, can cause cramping and alteration of menses. Most women just stop having a period on them, but some women don't, and some women still have intense cramping over their periods. The other trouble is although they're super quote-unquote quick and easy, cramping is the most intense among IUD insertion. And it is now kind of a hot button topic in a small variety of people that actually are arguing that it can be so painful for women to have their IUD placed that they're advocating that they should have some sort of procedural sedation or something done. So some people will have like an intracervical lidocaine gel. Some women are told, well, just take an ibuprofen right before you come into the office. That'll help. That's all you need. But for some women, in order to open up the os of the cervix and place the IUD, if they've not recently had a kid or if they haven't had multiple kids or what have you, it can be very challenging to force that os open and place the IUD, and very painful for some people. So there is a push that why can't they have it placed under with an IV and a little fentanyl and a dose of Versed or what have you. So I'm just throwing that out there. The two that you have are really the copper IUD or the Mirena. The copper IUD can cause a foreign body reaction and chemical changes, which are toxic to sperm. So that's how they interfere with fertilization. The copper is a great option for women who desire a high effective form of birth control but are sensitive to hormones, because you're really just making it from the copper and that foreign body reaction. You can still have heavier menstrual bleeding and cramping with the copper IUD, but they can be in place for 10 years and likely longer. The Mirena, which is the levonorgestrel containing IUD, work to prevent pregnancy by thickening cervical mucus, inhibiting ovulation, and alterations to the endometrium, which prevent implantation. So the main side effects can be bleeding irregularities, spotting, and some people just stop having a pregnancy. And right now, they say they can be used for 3 to 7 years, depending on the dose. So we do have some really good long-acting options for ladies now for oral or for contraceptives. All right, the next thing they talk about in your book are spermicides. I'm just going to quickly run through that and tell you that spermicides are chemical surfactants that kill sperm by destroying their cell membrane. They are over the counter. They don't have to be used with anything, but if they're used with a diaphragm or a condom, they can increase efficacy. Other point to know is that spermicide must be applied before intercourse, but no more than 1 hour in advance when used alone. So that can make it difficult for people because it kind of takes too much planning. And then we go into the idea of emergency contraception, which is EC. So that's contraception that is implanted after intercourse. So it's trying to protect unwanted pregnancy. They can have two ways to do that: an emergency contraceptive pill, which is an ECP, which is also called the morning after pill, or by inserting the copper IUD. Taking the emergency contraceptive pill is the most common. They can be progestin only, ulipristal containing pills, or estrogen progestin pills. The progestin only contraceptive pills are like Plan B, and those contain levonorgestrel. So like Plan B is a single high dose of levonorgestrel, which is a progesterone found in many of the combinations, but it's a much higher dose. They say that you take it within 72 hours of unprotected intercourse, but you can't even take it up to 5 days. They work by delaying or stopping ovulation. The Plan B, though, is not effective the levonorgestrel is not effective after fertilization has occurred. Those drugs themselves can cause heavy menstrual bleeding, nausea, abdominal pain, headache, and dizziness. The book says that these drugs will not terminate an existing pregnancy and will not harm a fetus if present. The next choice is 2 tablets of the levonorgestrel. You take 1 tablet within 72 hours of intercourse and the second tablet 12 hours later, or they can take the 2 together. And then there's the ulipristal acetate, which acts as an antagonist at receptors for progesterone. So remember, for the implantation of the ovum, the fertilized egg, you really need to have sufficient levels of progesterone. So this one alters that. Then the mifepristone is the RU486. And this is the emergency contraceptive pill that can prevent pregnancy or can cause an abortion depending on when it's taken. If mifepristone is taken within 5 days of unprotected intercourse, it will prevent the pregnancy from occurring and thus is considered emergency contraceptive. But if it's taken after that time, it will terminate a pregnancy if there's one present, and thus is considered an abortifacient. Then again, people can also place the copper IUD. Drugs specific for medical abortion then can be the mifepristone with misoprostol. And I'll let you guys read through that in greater detail. The interesting thing to me about that is the adverse effects. Successful abortion necessarily causes abdominal pain, cramping, and bleeding, and nearly all women will experience those events. 80% of women will experience transient cramping within 1 hour. Most women required an opioid analgesic for relief. That's pretty intense cramping. And some women will have bleeding for up to 30 days or more. 1% of women will experience severe bleeding, requiring measures including curettage, ureterotonic drugs, infusion of blood, fluids, or both. I hit the wrong, there we go. All right, so that covers wham bam oral contraceptives and other versions of contraceptives for female health. As always, please reach out if any questions or concerns.